Okay, so good morning, good afternoon, class. This is Steve. We're going to talk about the highlights and the take-home points regarding CPR. This presentation and what we're doing on Blackboard is geared more for BLS for healthcare providers. Although if you're not going into the healthcare field, that's perfectly acceptable for you to be a part of this course as well. I think many of you will be going into nursing, PA, EMT, some of that sort. Start off by saying I hope you've reviewed some of the training videos and the elaboration videos that are on Blackboard. If you haven't done so already, please make it a point to do so before you take your exam. Just to start off, before we talk about CPR, we want to talk a little bit about cardiac disease, heart disease, and cardiac arrest. As you see right here, it says heart disease kills more people each year than cancer. It's the #1 killer of adults in the United States. That statistic may change at the end of this year. Unfortunate pandemic going on, but for the last several decades now, it still has been the #1 killer of adults in the United States. If you see here, every year, 230,000 people, 325,000 people have a cardiac arrest outside of the hospital. Only 7.6% will survive. Now, when you talk about cardiac arrest, you're talking about sudden cardiac death. People who are not necessarily at the end of their life, but are basically just dropped dead out of nowhere and can survive if interventions are quickly and efficiently. But if you see that 7.6%, that itself is not a great number. If you live in New York City, the numbers are even more abysmal. And your chances of survival in out-of-hospital cardiac arrest in New York City is less than 1%. Not great. And when you think about it, some of the reasons for that, well, you have very high population density. You have very crowded traffic conditions. You have an underfunded EMS system, understaffed EMS system. Even under the best conditions, if you were to call 911 for a cardiac arrest, the average response time, the average funded response time for a level 1 cardiac arrest is 8 minutes in the city. That's 8 minutes for the ambulance to receive the call, drive through the traffic, get to the scene, and that doesn't even take into account the amount of time it takes for the EMTs and paramedics to get out of their ambulance and get into the individual who's having the cardiac arrest. That can tack on several more minutes onto the issue. So it's important to understand the difference in terms between cardiac arrest and heart attack. A lot of times these terms are used interchangeably. It may not be well understood what the difference is. When we talk about cardiac arrest, cardiac pertaining to the heart, arrest means stops. You're talking about sudden cardiac death. Heart has all of a sudden, for one reason or another, just stopped beating or stopped beating effectively. Usually due to some type of, for lack of a better word, short circuit in the electrical system of the heart, the wiring system of the heart that keeps it beating and functioning normally. So cardiac arrest is an electrical problem, as opposed to a heart attack occurs when a blood vessel that feeds oxygenated blood to the heart muscle itself, and there are several of them, but one or more becomes blocked up, usually due to a blood clot. And there are several reasons why that happens. But if that blood clot is not relieved or opened up in time, that part of the heart will become injured and ultimately die off. Now, the consequences of that can be minimal, and individual can make full recovery, or the consequences could be catastrophic and even lead to cardiac arrest itself. It's always important to know who's at risk for sudden cardiac death or heart disease or heart attack. One of the biggest risk factors and reversible risk factors is tobacco smoking. #1 controllable cause of heart disease. Long-term high blood pressure, otherwise known as hypertension, puts an enormous strain and beating on the heart and the cardiovascular system. high cholesterol, but more importantly, high bad cholesterol. You have certain types of cholesterol. You've got good cholesterol, which is your HDLs, your high density lipoproteins, and then your bad cholesterol, your LDLs, low density lipoproteins. The goal is to keep your HDLs high and your LDLs low. Physical inactivity, living a sedentary lifestyle, will never work in your favor. Like it or not, the human body was meant for physical work. Back in the days of the caveman, we didn't have Uber Eats or takeout or internet delivery or Instagram to deliver our food to us. We had to go out and kill it or run away to prevent it from being food. Overweight and obesity, I don't really like the term overweight so much. Obesity really deals with the ratio of body fat to lean body tissue. The higher your obesity index, the more risk you are for heart disease. Diabetes is a very underappreciated risk factor for heart disease. As a matter of fact, someone with long-standing diabetes has just about as much risk factor for a disabling heart attack as someone who's already had a heart attack in the past. Nutrition profile is always important. Diets that are high in saturated fats, trans fatty acids, simple carbohydrates tend to lead more so to heart disease than diets that are balanced in fruits and vegetables and fiber. And then there's a condition called metabolic syndrome, which, don't worry, that's not going to be on the test, but that's a combination of things like obesity, prediabetes, hypertension, high cholesterol, and sedentary lifestyle. So hopefully before a cardiac arrest occurs or before a heart attack becomes problematic, we can recognize some of the more common signs and symptoms of a heart attack. Most importantly, the most common one being chest discomfort, chest pain. Usually when you see somebody clutching their chest with their fist, that's a telltale sign something cardiac is going on. A person may also complain of lightheadedness, especially if the heart's not beating efficiently. Nausea or vomiting, and sometimes even vomiting without a preceding sense of nausea should give you an idea that something else is wrong. Sometimes chest pain does not exist. Sometimes people feel pain in their jaw, mistaking it for dental work, in their neck, either one or both sides, or in the back. More specifically, usually between the shoulder blades, what we call mid-scapular area. That area is more common in females than it is men, and should be taken seriously. A lot of times when somebody's having a heart attack, they'll feel pain in the chest, but that pain may also radiate to the arm or the shoulder. And even though there's nothing wrong with the arm and the shoulder, that's something called referred pain. What's happening is the brain is interpreting something that's going on in the heart as something that's going on in the arm. For lack of a better term, it's basically a mixed signal that's getting your wires crossed when the nerve impulses travel to the brain. And of course, shortness of breath is a very common symptom of a heart attack. If the heart's not pumping oxygen efficiently, the person's going to want to breathe harder to get more oxygen into their system. And then finally, the biggest problem or the biggest sign of heart disease is sudden death, or what we call sudden cardiac death or cardiac arrest. When the heart stops beating or stops beating efficiently to the point where oxygen does not reach the brain, the victim becomes unresponsive, unconscious, collapses to the ground, and if help does not occur very quickly, the person does not stand a very good chance of surviving. So when we talk about that, talk about some terms of when death occurs. The term clinical death refers to when a patient's breathing and heartbeat stop. So the moment that person collapses and that heartbeat stops, they are considered clinically dead. Does that mean the game is over? Absolutely not, because it says here may be reversible through CPR and other treatments like defibrillation and AED and the other advanced treatments that will be beyond the scope of this course. Biological death occurs when brain cells die, not reversible, usually within 10 minutes of clinical death, give or take. All right, but irreversible brain damage happens even faster than that. Once the heart stops beating, and this is an important take-home point, irreversible brain damage can occur within about 4 to 6 minutes. 4 to 6 minutes. Now, as I said before, When you rely on EMS to take care of this, well, what's the response time in New York City? It's about 8 minutes. So 8 minutes from beginning to end. That's why bystander CPR is such an important intervention in helping a person survive sudden cardiac arrest. Now, before we continue, I just want to clarify some definitions and age parameters for the purpose of CPR and CPR only. So when we talk about doing CPR on an infant, infant is considered anybody who's younger than 1 year old. And of course, if you're involved in doing CPR on a small baby or infant, if they're 11 months, 13 months, you're going to just use your best judgment. But this is really more for textbook purposes and testing purposes. Children are defined as 1 year to the onset of puberty. Puberty being the development of breast buds in females or underarm hair in males. And again, you would just use your best judgment if you had to make that call. And then from that point on, adults would be considered puberty and older. So if you found yourself having to do CPR on, say, a 15, 16-year-old, even though technically legally they're still children, for biologically and for the purposes of CPR, they're most likely adult onset. So what are we trying to do with CPR? Well, it says here, CPR moves blood to the heart and brain by giving chest compressions. So when the heart stops beating, it stops moving blood through the body and it stops circulating oxygen to the brain. As we said before, in 4 to 6 minutes, brain cells start dying, and once they die, they do not come back. CPR also provides periodic breaths to place oxygen into the victim's lungs. The bottom line is CPR can buy a few more minutes of survival until definitive arrives. It's a bridge to definitive care. Bottom line is, most cases, CPR by itself will not resuscitate a victim of sudden cardiac arrest. That's the reality. However, it can definitely keep this person alive and keep the brain cells moving until we get more definitive treatment. And it can actually prevent that irreversible brain damage from occurring. So in essence, we're not doing CPR to really restart the heart. Instead, we're doing CPR to preserve the brain. If we preserve the brain, then once we get the heart going again, this person stands a much better chance of living a more productive life outside of the hospital with fewer complications. So as I said before, CPR are the actions taken to revive a person by keeping the heart and lungs working. It's always best to have a teamwork approach in doing CPR, although you may be in the point where you're by yourself doing CPR, and that's okay. You just do the best that you can. But if you're working as a medical professional, either out in the field as an EMT or in the emergency room as a nurse or an aide, or on the floor or anywhere else where it may be involved, you want to really have a team approach. You want to have somebody taking the lead as the team leader. You want to have a systematic and organized approach to who's going to do what, and that takes practice. And hopefully at some later point in time, we'll get a chance to bring you back into school and into the classroom and into the labs and practice on some of the equipment. That still remains to be seen. Efforts must be tailored to suit specific circumstances of the patient. Well, whether they're a victim of smoke inhalation, sudden cardiac death, drowning, trauma, that's a little bit beyond what we're going to talk about here. But again, a team approach is really one of the goals we look for in the new CPR. And that's why the American Heart Association and other agencies that teach CPR have developed this, what's called chain of survival. The 5 links in the chain. First one is recognizing the cardiac arrest and calling for help, getting the resources over to you as quickly as possible. The next link is the actual physical CPR, putting your hands on that victim, compressing the chest, getting oxygen into their lungs, moving their blood, keeping the brain cells alive for a few more minutes until we get the real definitive treatment, which you see right in the here, defibrillation. Defibrillation involves delivering a jolt of electricity to the patient's heart to try to get it restarted again, or sometimes we use the word rebooted again, because we'll talk about a little bit later, when the heart stops, there's still some activity in it. Remember, we said cardiac arrest is an electrical problem, so it's going to take electricity to fix that problem. And then, of course, there's pre-hospital care, the work of the emergency medical technicians, the paramedics, and then the advanced care that occurs in the emergency room. For the purposes of CPR, we are responsible for learning about and studying about the first 3 links in this chain: calling for help, CPR, and defibrillation. If that defibrillator and those first three links aren't done quickly and efficiently, none of the advanced care that you see in the last 2 links are going to make much of a difference. CPR is so critical and defibrillation is so critical that it's been put into a major public health initiative to try to teach as many people about this as possible. So when you're making the decision to perform CPR, first things first, never go into a dangerous situation. The first thing you always assess when making the decision to help is, am I safe? Is there anything that could endanger me? Are the victims and bystanders safe? Are there any needles or drug paraphernalia? Don't run out into traffic to try to help somebody. Is this person on a slope, on a mountain, on a hill where you could fall and get hurt? Are there power lines down? Is there any personal safety issues? Are there animals like pets on the scene or hostile bystanders? It may be helpful if you have a first aid kit to have personal protective equipment like gloves, glasses, gown, but this is still a decision to be made by you whether you want to give help or not. And again, we're addressing this course kind of without the consideration of what's been going on with coronavirus. Obviously, that changes people's mind and people's decision, but there's still ways to protect yourself from that. And also, you got to think about learning this stuff if anybody whom you know or who you're friends with, or maybe, God forbid, somebody in your family succumbs to this illness. It's still a good thing to learn. So once you have secured the scene, once you make sure the scene is safe, nothing endangering, first thing you want to do is determine if the patient is unresponsive. Then you want to determine if they're pulseless and get somebody to help. That's one of the most important things to do. Get help. Nobody can really do this all by themselves, all on their own. So first thing you do is you check for unresponsiveness. Now, contrary to what you might see in TV and the movies, the best way to check for responsiveness is to gently tap the shoulders and say, "Are you okay? Are you okay?" If the person says, "Yeah, I'm okay, I'm just taking a nap here on the rug," well, great. CPR is not necessary. Please do not slap the person back and forth on the face like you see in the movies. Don't splash them with water. Don't rub your knuckles into the sternum. It's a simple tap on the shoulder. "Are you okay? Are you okay?" They may respond, they may not. What you also want to do is look for any obvious signs of life. Are they breathing? Are they moving? Are they talking? If you see them they're not responding and you see them taking deep, huge breaths and moaning or groaning, well, very likely they don't need CPR. If they're talking to you and saying, "Yeah, I'm okay," or "No, I'm not okay," they don't need CPR. If the victim actually tells you, "Yes, I'm having a cardiac arrest," well, got news for you. They're not having cardiac arrest. They may need help for some other things, but they're not in cardiac arrest. If they're swinging your hand away and they don't want your help, they're not in cardiac arrest. But if there is no responsiveness, no signs of life, have a bystander call 911 or call yourself if alone. Now, here's a caveat. If you're by yourself and there's nobody around, and for whatever reason you don't have a cell phone on your person, or maybe your cell phone's not working, not charged, what do? Do you start doing CPR or do you try to get help? Well, here it is. In the adult victim, if you are by yourself and nobody around, once you determine unresponsiveness and no signs of life, go wherever you can, find a phone, call 911, or somebody to call 911, and come back. The reason why you want to leave and come back is because we want to get defibrillation to that patient as quickly as possible. Remember we said earlier, CPR is only a means to an end. The definitive treatment is for that person to be defibrillated. So the faster we can get that defibrillator, either by EMS or fire department or rescue personnel to that person, the better chances of their survival. Okay. So like I said, if it's unresponsive, immediately activate EMS. The only condition that might be an exception to what we just talked about is if there's a condition caused by something other than heart disease. So for example, head injury, or maybe they were drowning, or maybe they inhaled smoke. If it's something where there was definitely a matter of them not getting oxygen into their lungs, then it's a different story. Then you would want to do 2 minutes of CPR and then make that phone call. A little different with a child or infant. Activate EMS after 2 minutes of resuscitation. Why would you want to do 2 minutes of resuscitation in an infant and child? Well, most children do not, and babies, do not go into cardiac arrest because of heart-related problems. They don't short-circuit their hearts because of long-standing heart disease like adults do. Sometimes, but it's not the rule. Children and infants usually go into cardiac arrest because they've had long-standing respiratory problems. Severe asthma attack, pneumonia, whatever, the choking. So when a child or infant goes into cardiac arrest, they most often need oxygen as quickly as possible, and they need that oxygen circulated into their body as quickly as possible. So that's the exception there. If you're alone and you find an unresponsive child and you have no means of getting help immediately, give 2 minutes of CPR, then go make the phone call or get the help and come back. That being said, once you determine that there are no signs of life, you want to check the patient's pulse. Should be done at the same time as evaluating breathing. So to check for a pulse, you want to check for the carotid artery in the adult or child, the brachial artery in the infant. I'll talk more about that in a moment. The carotid artery, the carotid pulse, can be found right between the Adam's apple and the muscle on the side of the neck called the sternocleidomastoid. It's not really sure you see here. It's the best way I can determine it. You want to take 2 fingers and try it on yourself. Try to feel your Adam's apple. Everybody has one. And slide your fingers just about a half an inch or two to one side or the other. Don't do both or you'll get very dizzy and lightheaded. And you'll feel the pulse. Boom, boom, boom. That's the heart pumping blood through each beat through that major blood vessel. Now when we check for a pulse, we want to check for no more than 5 to 10 seconds. Might remember that for future purposes. Hint, hint, hint. 5 to 10 seconds. Now here's the thing. Pulse checks are hard. Even experienced, well-trained clinicians, a lot of times in the heat of the adrenaline pumping and the excitement, have a hard time determining the pulse. I can't tell you how many times I've worked in the emergency room, worked up cardiac arrest, and had some novice, doctor, resident, whoever, saying, hold CPR, I'm feeling a pulse. 10 seconds goes by, 15, 20, 30. Doc, should I start CPR? No, I think I have a pulse. 45 seconds, 60 seconds. I still think I'm trying to feel. I don't know. Well, what's going on? Every second that goes by that this individual thinks they're feeling a pulse and is not sure, the victim's not getting any oxygen to the brain. Brain cells are dying. So the bottom line is, in 5 to 10 seconds, you're not absolutely 100% sure that you feel a pulse, start CPR. It'll only be better than worse. If you definitely feel a pulse, then don't do CPR. If you put your fingers on the person's neck and they say, what the hell are you doing on my neck? Don't do CPR. But if there's any shadow of a doubt, it's always better to start the compressions. And we'll talk about compressions in a minute. Unless that person is showing obvious signs of life. And just to demonstrate for the infant, and this is always a trick question, the infant Infants have short, chubby necks. Also, by placing your fingers on the neck to try to check a pulse on an infant, you can actually stimulate whatever heartbeat they have to slow down. That's why we don't like to do carotid checks on infants. So what we do is we check for a brachial pulse. The brachial pulse is found in the brachial artery in the middle of the upper arm, as you can see in the diagram here. Place your fingertip over the first 2 or 3 middle fingers over the brachial pulse area, right on the middle of the upper arm. Press lightly, and same parameters, 5 to 10 seconds. We'll talk about a little bit of a difference in infants later on, but same thing. If you don't feel a pulse and there's no signs of life, start CPR. It's going to be a little exception to that rule later on we'll talk about. And remember, we check a brachial pulse only on the infant. When we're talking about checking a pulse on a child, remember child, 1 to the onset of puberty, we check the carotid pulse. Probably a question on your exam. That question wrong because I think it's a trick question. It's not a trick question. You just got to remember the parameters between infant, child, and adult. Speaking of adult, once we make this decision that this person is pulseless and has no signs of life, we need to do CPR, cardiopulmonary resuscitation. One of the most important components of doing CPR is doing good, effective compressions. So what we want to do is we want to line up, we want to put the heel of your hand right in the middle of the breastbone, the sternum. You want to lock out your arms, lean forward, and you want to give 30 relatively hard and fast compressions, counting very rhythmically. 1, 2, 3, 4, 5, 6, 7, 8, 9. You get the point. You want to push hard, you want to push fast. In the adult, you want to push at least 2 to 2.5 inches, and you want to allow full recoil. As you'll see on the training videos, you don't want to do compressions with your arms. You want to do it with your upper body weight. Most of the motion should be coming at the hips, not the arms. So you want to really lean forward, and I'll show some pictures in a few moments. Then after 30 compressions, we want to open up the airway, pulling the head back and the chin up, a head tilt, chin lift, and we want to try to get air into that patient's mouth. There's a couple of ways to do that, but we also want to do breathlessness. How do you determine breathlessness? You basically look, listen, and feel. You can do it at the same time you're checking pulselessness as well. You want to look for chest rise. You want to feel for any air on your cheek. Again, not taking into account what's going on these days. And you want to hear if they're making any noise while they're breathing. Now, there are a number of different ways to get oxygen into this person's body so the heart can circulate it around. Well, you've probably seen mouth-to-mouth on many TV shows. There's mouth-to-face shield, little plastic shields that people can carry in their wallets. Mouth-to-mask, which is the most preferred, and then there's a bag mask system, which I'll talk about in a moment. Now, probably anybody on TV has only seen somebody given mouth-to-mouth. Now, what's going on? You see the rescuer here, they're pinching the mannequin's nose. They have two fingers on the chin bone. They're pulling the head back to open up the airway. If the head's flexed forward, the air's not going to go in. By pulling the head back, you're actually pulling the tongue off the back of the throat and opening up a passageway. If she's not pinching the nose, well, the air that she breathes in the mouth is just going to go right in the mouth and out the nose and blow a big wad of snot on her face, and I don't think she wants that. Now, how is this working? Well, when you breathe in air, the ambient air, the room air that you're breathing in, has 21% oxygen, give or take. Most of the air you breathe in is nitrogen. Your body doesn't use that, it just breathes it right back out along with some carbon dioxide. But when you take a breath of that 21% oxygen, your body is only absorbing about 5%. So when you breathe out, do the math, you're breathing out 16% oxygen. So if you're breathing into somebody's lungs 16% oxygen, that's enough oxygen to keep those brain cells moving around for a while. assuming you're doing good, effective compressions. Now, of course, how many people listening to this video are actually going to want to do mouth-to-mouth on site, I don't know. And if you do, please don't let me know about it. Maybe you want to do it if it's a family member, God forbid, or a friend that you know, but most of the time, a well-meaning bystander is not going to want to do mouth-to-mouth and expose themselves to any diseases. That's okay. It's perfectly acceptable to just do compressions only. We'll talk about that in a few moments. But if you have any type of first aid kit, or if you're a professional rescuer, you probably have something called a portable face mask, or sometimes called a pocket mask, even though it doesn't really fit very well in your pocket. A pocket mask is a barrier device that goes over the patient's face, and it has a one-way valve that you can breathe into. And when the patient breathes out, it diverts the air away from your body, and it allows you to give breaths without making intimate contact with the individual. It's done basically the same way as giving the face. You tilt the head back, you try to get a good seal. For professional rescuers, sometimes they have an inlet to apply extra oxygen. But it's usually the most effective way to give ventilations, especially if you're a single rescuer. Another device that's very commonly used is something called a bag valve mask device. So what you can see here, you have two rescuers using this device. One rescuer is holding the mask, making a good tight seal over the victim's face. The other EMT is squeezing this bag, what they're doing is they're pushing air into the individual's lungs. Usually the preferred method, if you have two or more rescuers, is not preferred method if you're yourself. As you can see that in order to effectively use a BVM can be used by one person, but they really have to be placed at the head of the victim. To go back and forth between doing compressions and then setting up the BVM, then back to compressions and setting up the BVM, very difficult, very inefficient for a single rescuer. If it's a single rescuer, your preferred device is definitely the pocket face mask. Now, as I was saying before, it is perfectly acceptable to perform hands-only CPR if no barrier device is available. As I said before, nobody's going to sue you for not doing mouth-to-mouth resuscitation. The interesting thing is when a person goes into sudden cardiac arrest, there's still oxygen in their blood. For anybody that goes diving, goes swimming and swims underwater and hold your breath, how long can you swim underwater and hold your breath? Some people a couple of minutes. Well, there's usually a couple of minutes worth of oxygen in a person's blood when they stop breathing. The problem is, if that oxygen is not getting to the brain, the person's not going to survive. So if you're going to do CPR with just hands, just compressions, and choose not to do mouth-to-mouth, you're still doing something to help that individual. You're still buying them extra minutes until definitive care arrives. Now, the standard of CPR is always to do 30 compressions with breaths, compressions with breaths. Tell you a little secret, there's been some research recently suggesting that in a few minutes of working up a cardiac arrest and doing CPR, maybe it's even better not to do the rescue breaths. They think that there's some thought, but it's not the standard yet, that just doing continuous compressions in the first few minutes might be more beneficial. Just the action of squeezing the chest and releasing the chest tends to draw a little bit of oxygen and air into the lungs by itself. That's just between you and me. That's not going to be on the exam, and that's not the standard that we're teaching, just for your knowledge. Little fun fact there. So in putting it together, when we are initiating CPR, we like to do it in what's called a CAB sequence. C stands for circulation. First thing we want to do is check for the pulse, any obvious signs of life. We want to send somebody for help. Then we want to open up the airway by tilting the head back, and we want to look, listen, and feel for breathing. If a problem is found, take appropriate steps. Proper treatment, not necessarily in ABC order. So it really depends on what you find first. So in initial ventilations and pulse check, heart stoppage is the reason most apneic adults are not breathing. Apneic means not breathing. So one of the most common reasons is because their heart stops. When the heart stops, the breathing usually stops. As I just said before, oxygen often still in the patient's bloodstream. Start with chest compressions, not ventilations. If anybody is in this class that's a little older like myself and took CPR many, many years ago, it used to be the reverse. They used to start with ventilation and then check for a pulse and then do compressions. The compressions are really the most important thing. So you always want to start off with compressions before ventilations. Now, let's talk about how to position the patient. So you want to lay the patient supine, meaning face up, back on the ground before attempting to open the airways, that's breathing and circulation. Be careful if you think there may be a spinal injury. If a patient is on the bed or a couch, you cannot effectively do CPR if they're on a soft surface. So they need to be, with, as much as possible, moved off of that bed and onto the floor. If you can't do it, you can't, but you really want to make the best effort that you can. There are times when a patient will have a pulse, will have a heartbeat, but they will not be breathing, or at least breathing adequately to sustain life. Could be due to drowning, could be due to a stroke, could be due to a drug overdose, in which case you would not do compressions, rather you would do rescue breathing. Just take over their breathing until help arrives. And again, going by these age parameters, rescue breathing in an adult would be 1 breath every 5 to 6 seconds. This is just something you'll need to kind of commit to memory. In a child, it's 1 breath every 3 to 5 seconds. Same thing with an infant, 1 breath every 3 to 5 seconds. This is assuming that they do have a strong, palpable pulse. Children and infants tend to need oxygen a lot more than adults do. So that's why the rate in children and infants is a little quicker than in adults. Now, whether you're using mouth-to-mouth, mouth-to-mask, BVM, whatever the case may be, you want to avoid overinflating the lungs because you can cause something called gastric distension. Once air finishes filling out the lungs, if you're still pushing air into that airway, it's only got one other place to go. It's going to go into the stomach, causing the stomach to blow up, and that can cause 2 serious problems. Well, if the stomach blows up, I don't mean blows up like a bomb, I mean just inflates, it's going to make it more difficult to inflate those lungs because it's going to be pushing up against the lungs, and it's also going to be causing regurgitation or vomiting. And we don't want that to happen because that can be a mess itself. And most people do not go into cardiac arrest on an empty stomach. Trust me from experience, I can tell you that. So to avoid that from happening, make sure you have the patient's head positioned properly. Remember the head tilt, chin lift. Avoid forceful ventilations too quickly delivered. Each ventilation should be delivered over about 1 second. And how do you know you're ventilating effectively, whether it's mouth-to-mouth, mouth-to-mask, or BVM? Simple. All you need to do is just see a little bit of chest rise. If you're given that breath and you see that chest expand just a little bit, you've inflated those lungs enough to get adequate amount of oxygen into their system. Now let's say that you're assessing the patient. They have obvious signs of life, they have a pulse, they seem to be breathing adequately. What would you do? Well, the best thing to do at that point is to turn the patient over to their left side and keep an eye on them until EMS or whatever professional rescuer arrives. This is called the recovery position, and it does a few things. It allows for drainage from the mouth, prevents the tongue from falling backwards and causing an airway obstruction. Also, if they vomit, it will not go back into their lungs and cause aspiration. So you can see how it's performed over here. You have the right leg bent over, straight left leg. You have the right arm cradling the head, the left arm preventing from rolling over. It's always better to position them on the left side rather than the right side, if it's possible. Positioning on the left tends to reduce the chances of them vomiting just because of the anatomy of the stomach and the digestive system. Okay, and once again, If you have any questions about anything we're covering or anything in the videos, please feel free to post them on the discussion board so we can share with the rest of the class. Okay, so going back, checking for circulation. Before beginning CPR, confirm patient is pulseless. And again, if you're not absolutely 100% sure that there's a pulse, do CPR. Checking for pulse in a children. Remember, where do you check a pulse in an unresponsive child? You check the carotid pulse, just same thing as you do with an adult. Only in the infants do you check the brachial pulse, as we were talking about. Now, I want you to pay attention to this slide for a moment. Checking for circulation. In infant, check for the brachial pulse, but this is where infants differ a little bit than adults. If the infant or child has a pulse slower than 60 beats per minute, begin CPR. 60 beats per minute. So even if an infant has a pulse, if that pulse rate is too slow, it's not be enough to get the job done, and it's not going to be enough to get enough oxygen to the brain. So what do we do? When we assess that pulse, do we really time them for a full 60 seconds to see if they're beating 60 times a minute? No, it's subjective. Feel the pulse. Think to yourself, is there a pulse? And if it is it fast? Is it slow? Or is it normal? So think about that for a minute. If you can hear me tapping out, if you feel the pulse and it's going like this, that's definitely more than 60 beats per minute. All right, good. This child does not need compressions. If you feel a pulse and it's going like this, that needs CPR. That's definitely less than 60 beats per minute. Now here's the question. What seems like it's in between? Are you going to time that for a full 60 seconds to make sure it's 58 beats or 62 beats? No. You're going to use your best judgment. If you feel a pulse at that rate and that child or infant looks listless, lifeless, unresponsive, you're going to go ahead and do CPR. Again, doing something is always better than doing nothing. So going back to what compressions do, the compressions cause increased pressure inside the chest and possible actual compression to the heart. Blood is forced out of the heart into the circulation. When the pressure is released, that's also just as important, the heart refills. So when you're pressing down on the chest, it's just as important to push hard, push fast, but let the chest come all the way up to allow what's called full recoil so the pump can fill up again. And again, look at the technique that you're seeing here. Again, it'd probably be better off to look on the videos that we have posted, but the arms are locked out, the fingers are interlaced, the heel of the hand is on the sternum, the rescuer is leaning forward, not backward, so there should be almost a 90-degree angle between the rescuer's arms and the victim, where she's going to push straight down and let straight up. So when you're delivering compressions in the adult, you want to press the chest down at least 2 to 2.5 inches. Test question, I'll give you that. Fully release pressure, do not bend the elbows. Do not bend the elbows. If you bend the elbows, that means you're compressing with the arms, and you're going to get tired very quickly. Do not lift your hands from the sternum. You don't want to use the patient as a trampoline. When you're providing ventilations, you're going to do sets of compressions to breaths, compressions to breaths. And as I said before, if you're the lone rescuer, using mouth to mask is the preferred technique. So let's just go over a few parameters here. Remember, age-wise, adult is considered puberty and older. Child is considered 1 year to the onset of puberty. Infant is considered birth to 1 year. Compression depth in the adult, at least 2 to 2.5 inches. That's what it should say. When you're compressing in a child and infant, there's no hard, fast rule. The best way to remember it is 1/3 to 1/2 the depth of the chest. 1/3 to 1/2 the depth of the chest. You can actually press a little bit harder in children and infants because they have softer rib cages and are not likely to break an older adult would. Rate pretty much the same as all, at least 100 to 120 compressions per minute. Okay, now this is where things get a little tricky. Compression to ventilation ratio. How many compressions to how many breaths? In the adult, it's always 30 compressions to 2 breaths. 30 compressions to 2 breaths. Whether you have 1 rescuer, 2 rescuers, 5 rescuers, doesn't matter. 30 to 2. In a child, it's a little bit different. If you're a single rescuer doing CPR on a child, the ratio of compressions is 30 compressions to 2 breaths. 1 rescuer. If you have more than 1 rescuer, then we're going to reduce the ratio of compressions to breaths to 15 to 2. Same thing with the infant. 30 to 2 with 1 rescuer, 15 to 2 with 2 rescuers. We're not going to really focus on the newborn right now, so you can ignore that. So, how to remember this? All single rescuer CPR is always 30 compressions to 2 breaths. All CPR in the adult, 30 compressions to 2 breaths. 2 or more rescuer in the child and infant, 15 to 2. Just try to remember that. Now, when you're doing CPR technique in a child, your technique can vary a little bit depending on the size of the child. CPR is pretty much conducted as an adult, except the heel of one hand is used for compression. So if it's a small child, as you can see right here, you don't want to really squash the chest. You always got one hand on the forehead, kind of maintaining the airway, and using one hand to perform compressions. However, if it's a larger child, and you're still doing child CPR, it's perfectly acceptable to use 2 hands, especially if your one hand is getting fatigued. Infant technique is a little bit different. When you're doing compressions on an infant as a single rescuer, you want to use 2 fingers right between the nipple line and 1 finger width towards the feet, as you can see right here. And again, the only way to really appreciate this is to watch the demonstration videos that we have posted. Apply a slight tilt when you use the chin lift to open up the airway. So when you're giving a breath to an infant, you do not want to pull the head back as far as you do an adult. So you can actually pinch off the airway. Now, if you see here, when you have multiple rescuers, 2 or more, working on an infant, the compression technique is a little bit different. Then we're going to use what's called the 2-thumb encircling hand technique. Basically squeezing the baby like a watermelon. 1 rescuer does the compressions, 15. The other rescuer will do the ventilations, 2. Again, if your patients do have a pulse and for whatever reason you just have to do rescue breathing, the rates are a little bit different. The breath should always be just about 1 second, but in the adult you want to give about 10 to 12 breaths per minute. That translates into 1 breath every 5 to 6 seconds. In the child, you want to give a little more, 12 to 20 breaths per minute, which translates into 1 breath every 3 to 5 seconds, and same with the infant, 12 to 20 breaths per minute, 1 breath every 3 to 5 seconds. So how do you know your compressions are effective and your CPR is being effective? Well, have someone else feel for a carotid pulse during compressions. Watch for chest rise during ventilations. Listen for exhalation of air. And if the person gets up and says, "Stop pressing on my chest," then you know you've done a really good job. So what are some situations, I'm going to skip over a slide that's actually not necessarily. What are some situations in which you would interrupt CPR? Well, whenever you interrupt compressions, do it quickly to minimize time during which the patient is not circulating blood. So if you're doing your 30 compressions and then you're trying to give your 2 breaths, maybe you're having a hard time getting the seal with the mask. Maybe you're not getting the chest rise. Maybe something just not right. Maybe there's a blockage. Do not overdo or do not use an extended amount of time trying to get those ventilations. And remember, the most important component is the compressions. So if you're not getting effective ventilations in that short time that you're trying to give ventilations, abandon it. Go back to doing the compressions and then try to recheck your technique afterwards. There should never, theoretically at least, be no more than 10 seconds in between cycles of compressions. Because when you're doing CPR compressions, you're trying to build up a little bit of pressure in order to get that blood flow moving effectively. Think about if you have a spray bottle sitting around in the closet. You want to do some cleaning. You have the cleaning fluid in the spray bottle, but it's been sitting around for a while. You squeeze the trigger a couple of times, nothing happens. Squeeze it a few times more, you get a little bit of squirt coming out. Then finally, after you squeeze it a number of times, you get a good tight stream of cleaner coming out of the bottle. Well, it's kind of like what happens with the heart. The first few compressions are trying to build up pressure until the next few compressions effectively circulate through the body and the brain. Once compressions stop, that pressure diminishes very quickly, and then you got to start all over again from square one. So obviously, when not to begin, terminate, CPR should not be initiated when the patient has a pulse. Obvious pulse. Again, as I'm saying before, if you're not sure, if you're not 100% sure if the patient's got a pulse or not, it's better to err on the side of safety. If you start doing compressions and the patient says, ow, 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 get off my chest, please, stop, well, then you know, okay, stop doing CPR. There are times even when a patient is pulseless that CPR should not be initiated, even though there's no pulse. For one thing, obvious mortal wound. So if a patient's body's on one side of the room and the head's on the other side, really no amount of CPR is going to work. Now, what defines an obvious mortal wound? That's a good question. None of the textbooks will really define the upper and lower parameters. All I can say, it's got to be a wound that's so devastating that the physical application of CPR would pretty much be impossible. For those of you who don't know rigor mortis is stiffening of the joints as muscles start decomposing. It happens within maybe 30 to 60 minutes, a little bit more, a little bit less, when the heart stops beating. Most often you'll feel it in the jaw first. It'll start stiffening up, and then the rest of the body will start stiffening as well. Because it actually takes energy not just to contract the muscle, it takes energy to release a muscle as well. And no more energy circulating in the body, the muscles tend to lock up. Obvious decomposition, well, you'll probably smell that before you even see that. But yeah, you don't ever try to work up something that's decomposed. Dependent lividity is an obvious sign of death. It's when the person's been down for a long enough period of time that the blood vessels start breaking down and blood starts leaking to the dependent parts of the body. So if the person's lying on their back, all the blood starts pooling as gravity is pulling it down, and you'll see much discoloration and bruising on the dependent parts of the body. If the person's lying face, you're going to see it all in the front of the body. That's an indication that it's too late. They're obviously dead. And then there's the presence of what's called a do not resuscitate order. Some people have lived their lives and made the decision that they do not want any attempts of resuscitation on their life. Maybe they have a terminal illness. Maybe they're up in the years and decided they had a good life. It's a personal decision for everybody. If it's a valid DNR, then it should be respected. Okay. Once CPR is started, you need to continue it, unless a few circumstances occur. Spontaneous circulation and breathing occur, obviously the signs of life. Another trained rescuer takes over, and we really should be having alternate rescuers. You never want to do compressions for more than 2 minutes because fatigue will set in. You turn care over to the patient, to someone of higher level of training, like an EMT, paramedic, nurse, doctor. If you're too physically exhausted to continue, that's valid. If you're alone in the woods in a desolate area and somebody you're with collapses, you can do the best you can, but you're only human. Or if you receive a no CPR order from a doctor or physician, maybe work in the emergency room and the doctor decides to call it, or if you're an EMT in the field and nothing's working and you call the physician and said, permission to terminate, but that's for the doctor to determine, not you. So let's talk about airway obstructions, choking, clearing airway obstructions. Well, the most common cause of an airway obstruction in the unresponsive, unconscious individual is their own tongue falling in back of their throat and blocking off the airway. Contrary to popular belief, you cannot swallow your own tongue. It just doesn't happen. Um, Otherwise, what happens is foreign body airway obstructions can get past the epiglottis and can lodge in the trachea right above the vocal cords. Now, an airway obstruction can be mild or incomplete, or it can be severe incomplete. Evidence of an incomplete airway obstruction: the patient can speak, can cough, can exchange air. They're moving air. They may be coughing very hard. They may be telling you, I'm choking. If a person can tell you, I'm choking, they're actually not really choking. Encourage the patient off to dislodge their own object. Do not slap them on the back. Do not shake them. Doing so might actually force the object, whatever they're choking on, to go further down the airway and then become a complete airway obstruction. If it is a severe airway obstruction, you're going to see that the patient cannot cough or has a very weak, ineffective cough, starts turning blue or gray, will usually show universal choking sign where they're clutching their throat with both hands, which I probably should have shown a picture of here, but I apologize. In which case you need to act. And the best way to act is employing what's formerly called the Heimlich maneuver, but we just basically refer to as abdominal thrusts. So what you want to do is get behind the victim. First of all, confirm that they're choking. Say, sir, ma'am, are you choking? If he says, yeah, I'm choking, they're not choking. But you can see here, you see that universal choking sign. Basically, they're just going to acknowledge with either a nod or whatever. To get behind that individual, you want to make a fist with one hand. You want to turn that fist so the thumb's facing right above the belly button. Then you want to take your other hand and wrap it around the fist. And then what you want to do is you want to push in the stomach. You want to do thrust. You want to push the stomach in and up, in and up. As you can see with this arrow pointing in and up, in and up. And you're basically going to keep doing that until the foreign body is relieved or until the patient passes out, becomes unconscious. And I'll talk about what to do after that. Place the patient's supine position and begin CPR if the patient becomes unconscious. And remember, supine means face down. If the patient's conscious, but you can't sit or stand, but cannot sit or stand, or you're too short to reach around the patient's to deliver thrusts, I don't think it's really practical to get a step stool to wrap your arms around the patient. You may have to lie them down and try to press down on their stomach to dislodge that object. Now, what if a patient is obese or pregnant? Obviously, you don't want to compress a pregnant woman's belly in the late stages of pregnancy. In that case, you would do chest thrust. You would do the same technique, thumb in, hand around the fist, and you would put your fist right in the middle of the breastbone, the sternum. Pretty much just as effective, but without any damage to the abdominal contents. If that choking patient becomes unresponsive and collapses, put them down on the floor and start CPR. It's a very good chance that once they become unconscious and all the muscles in the body, including the throat, relax, that foreign body or that piece of choking material will be dislodged. Perform CPR. Then, before giving any kind of rescue breath, take a look inside the mouth. If you see something in there, take your finger and sweep it out. If you don't see anything in there, leave it alone. We do not do any blind finger sweeps. So only sweep if you see something. And again, you're just going to keep doing that, compressions and attempted breaths, until professional help arrives. And really, the goal of what we're trying to accomplish here is really just to intervene in the first few minutes of the emergency. All right, unless you're taking an advanced class like EMT, which I would love anybody to consider for next semester, and you can always email me for information about that. But unless really, we're just focusing on the first few minutes. If you're a nurse in the floor until the crash team arrives, if you're working in the emergency room and you notice that the patient is not in distress, getting the doctors and the orderlies to help out. If you're a bystander in the street until 911 gets there, it's just for those first few minutes. So, summary of actions on a conscious choking patient. In the adult, you're going to ask, are you choking? Are you choking? And then you're going to give abdominal thrusts, just like we showed. In the child, you're going to do the same thing, but you're not going to use as much force, obviously. If you have a conscious infant choking, the technique's a little bit different. So there's a series of 5 back blows, 5 chest thrusts. We're going to go over that in a moment. But either way, if a patient has been choking on a foreign body and they relieve the foreign body and they're moving air, it's very important to make sure that they get medical attention. They get seen in basically an emergency room, because that airway, that trachea, that windpipe has sustained some type of trauma. And once the object is dislodged, now we have to worry about swelling and inflammation that occurs later on. So we want to make sure that that person follows up with good medical care. And as I was mentioning before, the technique on an infant is a little bit different. As I said, with the adult, you don't want to slap them on the back. You don't want to shake them. Infants, because of their small size, you can kind of get away with that. So first thing you want to do is recognize the fact that the infant's choking. Is the infant's not crying, they're silent, they're turning blue, they have a distressed look on their face. Well, as you can see here, the rescuer has the infant straddled over his arm, over the lap, face down, using gravity to help, and he's giving 5 back blows, 5 slaps right between the shoulder blades to help dislodge that object. Then they're going to turn the infant over and give 5 chest thrusts. And then he's going to pick up the baby, reevaluate. The baby's still choking. He's going to go back and repeat the procedure. If the airway becomes clear, probably the first thing that's going to happen is that he's going to start crying like crazy, which is music to my ears. If the baby becomes unresponsive, open up the airway, look for the foreign body. If you see, you sweep. No see, no sweep. Attempt to ventilate, start CPR. Remember, children are much, in the infant, you want to attempt the ventilation first because they're much more responsive to oxygen deprivation. So let's move on. So again, let's talk about the chain of survival that we talked about earlier. So immediate recognition and activation of EMS once you recognize that a cardiac arrest has occurred. Early CPR, physically compressing the chest, getting air into the body to circulate around, to buy those few extra minutes of brain activity. But the best CPR, the earliest recognition, will not make a difference if we don't get a defibrillator, an automatic external defibrillator to that heart and shock it back into the rhythm. Most of the times, with very few exceptions, CPR by itself will not resuscitate the patient. We need an AED. And that's why you see them all over the place. You'll see automated external defibrillators in gyms, in schools, in public buildings, arenas, casinos, airports. The quicker access you have, the better chance of survival. So like it says here, coordinating numerous means of assessment interventions means together maximize the chance of neurologically intact survival. So maybe you're the one that recognizes the cardiac arrest, you send somebody to go get the first aid kit, send it to another person to go get the AED, tell another person to call 911. Being the team leader will mean the best chances of survival. So let's put all this together now. So management of cardiac arrest with the use of an AED. So we want to perform 1 and 2 rescuer CPR if possible. Take standard precautions. If you have personal protective equipment like gloves, barrier device like a mask, obviously use it. We want to get an AED as quickly as possible. Send somebody to call ALS, meaning EMS, when available, to continue with the chain of survival. Use a bag valve mask if you have multiple rescuers. So what does AED stand for? AED stands for Automated External Defibrillator. AED. A lot easier to say ED than Automated External Defibrillator. So what's going on with the heart when it first stops? Well, you'll see in a few moments that when the heart stops, it doesn't really stop completely. There's a period of time where when the heart stops beating, it kind of quivers and shakes and spasms, and that's something that we call ventricular fibrillation. It's a very technical term that you don't need to know about. That ventricular fibrillation will lead to cardiac standstill in just a matter of moments. But while that heart is quivering and shaking and spazzing out, there's electrical activity in it. And if that electrical activity can be fixed, person stands a very good chance of recovering. Now, you don't really have to know this, but there are different types of AEDs. There's semi-automatic, which advises you to press the button on cue, and there's fully automatic that does everything on its own. You don't really have to know that, but so as the point I'm trying to make, that the sooner defibrillation occurs, the more likely the patient will survive the cardiac arrest. So, for instance, when a person goes into cardiac arrest, every minute that goes by that they are not defibrillated, their chances of survival statistically decreases by about 8 to 10%. And this is kind of what I was showing you about. What you see on the left side is a representation of cardiac activity during cardiac arrest. See, it's kind of random, chaotic, doesn't have any rhyme or reason, then boom, they get hit with a defibrillator shock, and then boom, you have this nice, what's called sinus rhythm. Beep, 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 beep. I'm sure you've all seen that on TV, any type of medical show in the past. There are many different types of AEDs on the market. The American Heart Association, Red Cross, they do not endorse any one brand, but most brands all work on very similar principles. If you're working in a place where knowing first aid and knowing CPR is part of your job description, it's in your best interest to be familiar and get yourself familiar with the device that's used in your setting. So as far as coordinating CPR and AED, you want to interrupt CPR only when absolutely necessary and for a short period of time. You do have to stop CPR when the AED is actually analyzing and charging up. But for the most part, if you're going to apply that AED on the patient's chest, it should be done while CPR is in progress. So you come on the scene and you see that there might be a cardiac arrest in progress. If bystanders are doing CPR when you arrive, have them stop. Verify pulselessness no more than 10 seconds. And again, sometimes people do CPR when person's awake and breathing because they've seen it on TV. So you want to take that 10 seconds just to verify what's going on. All right, you're checking the carotid pulse in the adult. Again, even if there's a shadow of a doubt there's no pulse, intervene. If you have somebody to help you take over, have them do compressions immediately. If you're by yourself and you have the AED, hold off on the compressions. Use the AED first. The AED is the most important intervention right now. And that's assuming that you're all by yourself. So to use the AED, turn it on, obviously, attach the pads and the cables to the patient, stop CPR and analyze. You don't want to have CPR compressions going while the machine is trying to analyze the activity in the patient's heart. And one of the most important things you need to do is to make sure nobody is touching that patient while the machine is giving the shock. So yes, when you're intervening, you're going to have to expose that individual's chest, male or female. It's really no time for modesty. It's no time to be shy. This is life or death. Patient may have an extremely hairy chest, male or female, who knows? Most AED equipment comes with a shaving kit. You may have to take a moment to shave a couple of spots where you're going to put the pads on the AED. You don't have to shave the whole chest. Another trick that you may be familiar with, some kits have 2 sets of pads. Something that even works faster than shaving the chest. If you have extra sets of pads, American Heart Association sometimes recommends putting the first set of pads on first, and this is a really hairy chest, and then ripping them off, and then putting the second pair on. Duct tape works just as well, by the way. If you're going to do that, though, I would definitely recommend making sure that that patient is totally unresponsive, or that itself may wind up resuscitating them. If available, use pediatric AED pads. Now, you never want to use pediatric pads on the adult. It won't work. It won't deliver enough care, and it's just going to interrupt your CPR time. If you have a child and you only have adult pads, it is perfectly acceptable to use adult pads on a child, even on the infant, as long as the pads do not overlap. So if you have a small child and you're using the AED pads that are only adult pads, sometimes it's more appropriate to put one in the front, one in the back. So as you can see right here, one EMT is doing CPR, one EMT is setting up the AED, and most of them are very self-explanatory. They come with pictures, diagrams, directions, and most AEDs will actually give you voice prompts to tell you exactly what to do. All you got to do really is remember to turn it on. Now, you see the AED is in a very accessible spot. You have one rescuer doing CPR, one rescuer setting up the AED. The first thing she's going to do is turn the machine on. The machine's going to tell her to apply the pads. By convention, one pad is going to go under the right collarbone. The other pad is going to go on the left side of the rib cage. That's so that jolt of electricity can pass right through the heart. And most of the times the pads are diagrammed which goes which. One's diagrammed for the upper right, one's diagrammed for the lower left. To tell you the God's honest truth, even if you reverse them and put them backwards, it's still going to work. It's just by convention. Then the machine's going to tell the EMT to plug it in, plug the pads, cables into the machine, and then we stop CPR. So what's going on in that time is that machine is actually analyzing the electrical activity of the heart, reading it, and it's determining whether it's going to be a shockable rhythm or not. If it's in that wavy type of form that we talked about, ventricular fibrillation, that's a shockable rhythm. If it detects that it has a normal rhythm like you saw afterwards, it's not going to allow the shock. So it's going to analyze for a few seconds, and it's going to tell you if shock is advised. If shock is advised, then it's going to tell you to stand clear. But don't count on that. You want to tell everybody else to stand clear. You want to say, I'm clear, you're clear, everybody's clear. And right before you deliver that shock, you want to belt out really loud, clear! Make sure nobody's touching them. And then press that shock. Press that button. Now, once that shock has delivered, you immediately want to begin or have someone else begin CPR. You do not want to waste time trying to assess a pulse, trying to assess responsiveness. Most of the times the way AEDs are built these days, first shock will usually work, but it's going to take time. That heart has been stunned. It's been knocked out. It's going to take some time to recover itself. It could take up to 30, 45 seconds. So if you spend all that time trying to detect a pulse, what's not happening? The brain is not getting any oxygen. Brain cells are going to die. So the use of an AED is really, really easy. And hopefully sometime by the end of the semester, we will have a chance to bring you back to practice, test out, and certify. But I will keep you updated as far as how that progresses. But as far as using an AED, if you could just remember the 4 P's of AED: power, pads, plug, press. Power, turn the machine on. Pads, put the pad, bare the chest, put the pads on in the right place. Plug the pads into the machine so it can read the heart rate, and then boom, clear and press. And then once that shock has been delivered, we want to go right back into CPR, remembering to switch compressors, switch rolls after every 2 minutes. Now, the cool things about these CPR, these AEDs, that they're pretty much automatically programmed to time you every 2 minutes and alert you when it's time to switch and when it's time to reanalyze. But if you're really feeling exhausted and tired from the compressions, don't wait for the AED to tell you to get somebody else to take over. If you're doing sloppy compressions because you're tired, and most people don't realize it, effectiveness is going to be reduced. Chances of survival is going to be reduced. So you're going to perform CPR for 2 minutes, usually about 5 cycles of 30 compressions to 2 breaths, or 15 to 2 in a child, 10 cycles. Keep doing CPR unless the patient wakes up or shows obvious signs of life. Now, what happens if the AED finds no shockable rhythm? So it analyzes and it says no shock indicated, no shock indicated. Well, the patient's heart could be in some different types of rhythms, something called pulseless electrical activity, where it's showing some rhythm but it's not generating a pulse, or asystole, which is basically flatline, not a good prognosis. Resume CPR immediately, and hopefully EMS will get on the scene sooner than later. A couple of take-home points that still need to be reiterated. Compression should not be interrupted for any longer than 10 seconds. Compression should be at least 2 inches deep for the adult, at least 1/3 depth of the chest for infants and children with full chest recoil. If I'm repeating these points, it's probably something you should remember for your testing purposes. Rate should be at least 100 to 120 beats per minute. Rotate personnel. Don't let your ego get the best of you because you think you're strong and macho and you can do compressions forever. Nobody should be doing compressions for more than 2 minutes. Some special considerations for the use of the AED. All contact with the patient must be avoided during the rhythm analysis. So that's one of the most important points for the rescuer operating the AED to consider. The person at the AED is really kind of responsible for the safety of everyone around. Pulse checks should not occur during rhythm analysis. Everybody stay clear and really yell it out, clear. Make people jump out of your way. If the AED's shock is successful and the patient regains a pulse, regains signs of life, they start moaning, they start moving, yeah, reassess the pulse at that point. You may have to continue rescue breathing because even though the pulse is back, they may not be breathing adequately. Remember to avoid hyperventilation. Do not take the defibrillator off. Wait until EMS gets there because there's a very good chance they may go right back and rest, in which case you have to start the procedure all over again. And as I mentioned before, if you're a single rescuer with an AED, apply the AED and defibrillate immediately. Do not waste time doing CPR if you have that AED on hand. Expose the chest, put the pads on, analyze. If shock is indicated, shock, then begin compressions. As I keep reiterating, CPR is only a bridge to the definitive care of AED. When would you not want to use an AED, or what would the contraindications be? Well, the pads won't fit on the patient without touching each other. Very rarely that's the case. Usually if you can put one on the front, one on the back, that'll help. Cardiac arrest due to an injury, trauma, severe blood loss. Those type of injuries, those type of situations are not going to be responsive to AED. This person needs EMS and they need to be transported to a trauma center as quickly as possible. You can't jumpstart a car with no gasoline in it. If hypothermia is an issue as well, hypothermia is a strange situation. The person can very much look dead and feel dead, but still have some activity in their heart. And if you wind up defibrillating them, you might actually screw that up. And usually cardiac arrest secondary to hypothermia is usually not responsive to defibrillation until the patient is warmed up, and that's going to take advanced intervention. Obviously, do not defibrillate a soaking wet patient. So let's say, for example, you're in a gym, a local LA Fitness or whatever, and somebody collapses in the shower, and you make the decision to run in, render aid. Well, don't put the AED on while they're in the shower. Pull them out, get them dry, and then apply. They don't have to be bone dry, but you don't want to be sitting in a puddle of water while you're applying the AED. Do not defibrillate if patient is touching anything metallic or other people are touching. So say they're on a metal deck or something. You may have to move them out to a different area before applying the AED. If they have a medication patch on their person, usually a nitroglycerin patch or some other type of patch, fentanyl patch, with a gloved hand, not with a bare hand, remove that patch before defibrillating. If they have nitroglycerin in their system, they won't explode when you defibrillate them, but it may wind up splattering and getting on you once they get defibrillated. And once again, bears repeating, verbally and visually clear the patient before defibrillating. And make sure, see how she's not staring at the defibrillator, she's looking at her partner and she's looking at her surroundings to make sure that nobody is touching that patient, because you can wind up having two victims if somebody's making contact with that patient. I've seen it in the past. I want to take a moment to mention something called an AICD, or automatic internal cardiac defibrillator. Some people with heart disease or who have survived cardiac arrest in the past have a small device surgically implanted in their body that actually is wired directly to the heart, and it's an automatic defibrillator. And it's constantly monitoring the heart. And if the heart goes into one of those funky rhythms, we're about to go into cardiac arrest, it'll automatically deliver a shock. The amount of voltage, the amount of electricity that's delivered through these things is much lower than an automatic external defibrillator because it's already connected to the heart. It doesn't have to get through the skin, the muscle, the chest wall. The only issue with the AICD is if you see it, and if you can see it in the diagram, it looks like a little stopwatch poking out of the chest. Make sure the defibrillator pad is not directly over that AICD. You want to place it at least about an inch away. And also, if that defibrillator goes off while you're administering CPR, you really have nothing to worry about. You will not get electrocuted. It doesn't deliver enough oxygen. Maybe you might feel a tingle or something, but what's probably going to freak you out more is that this person's going to look unresponsive and dead, and all of a sudden they're going to jerk up quickly because the defibrillator just discharged. Don't let that freak you out. That's a normal occurrence. And once again, terminating resuscitation. Once you start resuscitation, you must continue until 1, the patient shows obvious signs of life, spontaneous circulation occurs, then applied rescue breathing is needed. Spontaneous circulation and breathing occurred, another trained rescuer can take over for you. You're presented with a DNR, or you're too physically exhausted to continue. All right, ladies and gentlemen, I would encourage you to please review the training videos posted on Blackboard. And please, 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 I want to hear any questions that you have about the material. This presentation has been a little bit experimental for me, so I'm not usually used to teaching online. So anything that you can contribute and that I can elaborate on, I'd be more than happy to do so. For HE 110 students, please remember to take the examination by the deadline posted. And thank you very much for your attention.